I am Dr. Cabanero, Ria, presenting for Dr. Peralta here in Valley Baptist Medical Center in Harlingen, Texas. Wanted to present to you today about a case, very interesting case, myedema coma in a patient with subclinical hypothyroidism, and wanted to just remind you guys, don't be fooled by the labs. So we all know that myedema coma is considered an endocrine emergency presenting with multi-organ dysfunctions. It's very slowed. For example, abnormal mental status and also hypothermia. The diagnosis is typically clinical and it can be differentiated from other causes of altered mental status. And subclinical hypothyroidism actually is a rare cause of myedema coma. And it's very rare, or a few cases are reported in the medical literature. So today I want to present a 62-year-old female with a longstanding history of bipolar disorder and epilepsy, who was bedbound and presented with myedema coma, and her lab findings were significant for subclinical hypothyroidism. So she was transferred from the psych facility to the emergency department after an episode reported of hypotension and increased altered mental status. And she had evidence of delirium, slowed speech, bradyphagia, and also no response to noxious stimuli. Her temperature was like 31.1 degrees Celsius. She was hypothermic. Her blood pressure was 113/58 on admission. And she was a GCS of 11/15. Her labs showed WBC of 3.6, and she met the clinical criteria for myedema coma using the myedema coma score, which above 60 has a high diagnosis for it, and she scored a 62. So she was immediately started on levothyroxine, leothrianin, and hydrocortisone. And interestingly, the patient also had 2 out of 4 SIRS criteria. So she was also started on IV fluids, antibiotics, and then while she initiated further studies. So you can see here in figure 1, she had non-pitting edema and lymphedema on both bilateral extremities that was very extreme. And her labs showed a TSH of 13.4, which also had a free T4 of 0.85, which was in the normal range. And her serum glucose was 48. Her UDS, cortisol, HIV, Hep A, B, and C, lactic acid, ammonia were all unremarkable. And her ABGs showed a PCO2 of 53. Soon after hospital admission, she actually deteriorated quickly, and her hypertension with hypoxia, her heart rate decreased as well, and she was consistent with hypercapnic respiratory failure, and her GCS worsened to 5/15. She was intubated and quickly sent to the ICU. Blood cultures, the fluids, and CSF was also unrevealing, and there was really no source of infection identified, and so the antibiotics were discontinued, and based on her labs, adrenal insufficiency was also excluded. Subsequently, she actually improved, and by week 2, she was switched to oral levothyroxine, and then on discharge, she had returned to her baseline. So our patient today had evidence of myedema coma with laboratory findings consistent with subclinical hypothyroidism with the elevated TSH and the normal T4. So although biochemical hypothyroidism is expected, this case highlights the importance of considering myedema coma when evaluating a patient who presents with altered mental status and hypotension. And it's good to recognize the absence of laboratory findings of hypothyroidism, and it doesn't really exclude a diagnosis. So treatment shouldn't be delayed considering the high mortality. I want to remind you guys, don't be fooled with labs, even if a patient presents with symptoms.
Are there any questions from the audience? Thank you for your presentation. I had a question. Can you describe the etiology of the myxedema coma in patients with subclinical hypothyroidism?
So it's interesting because I think she came in from the psychiatry facility without a diagnosis of primary hyperthyroidism, and it had been missed as a chronic condition. And so when she presented, she was already to the extreme point of untreated hypothyroidism, which is unfortunate when patients do come into facilities that already have a diagnosis of bipolar epilepsy, and special endocrine or basic endocrine diagnoses can be missed in these kind of situations. So it's very important to always follow up with that to prevent extreme cases like myedema coma.
Okay, thank you so much.